Hello, everybody, and welcome to BDC session on what everyone needs who treats with factor needs to know about inhibitors. Again, welcome, and let's get started. I have lots of great information to share with you. A few things that I'd like to set out there. First of all is how you can get the most from this session. So you can email questions to the speaker by using the ask a follow-up question for response at a later time. Please feel free to send any questions you might have concerning the presentation or anything else that comes up that we may discuss during the presentation. I'm happy to answer those questions. And make sure you give additional information at the end by filling out the evaluation. And all presentations are recorded and will be available to watch online at a later time. So keep watching the BDC site to see if you want to watch this again, or if you want to share with someone that wasn't present for this session, that there's some good information in this session. My name is Maria Tobar Herrera. I am a registered nurse, and my disclosure is that I am a speaker for NHF. I am located in Chicago, Illinois, and I was the HTC nurse at Rush University Medical Center for almost 9 years. But since then I have retired and I am home taking care of my granddaughter, but still very much involved with the bleeding disorder community and my local chapter, as well as NHF. So the objectives of this session. By the end of this session, participants will know what an inhibitor is, recognize inhibitor signs and symptoms, identify who is most likely to develop an inhibitor, and understand why yearly inhibitor testing is important. So what is an inhibitor? An inhibitor is an antibody that is produced by the immune system. Some antibodies are protective, like vaccinations. So all of us as children, or even as adults, we get our yearly flu vaccine. As children, we get an immunization or a vaccine to protect us from getting some sort of a disease. So we get these every year, and those are our vaccinations. For the flu, we get them every year, and those are our vaccinations, and that protects our body. However, there are other antibodies that form that work against our body. And so that's where the inhibitor comes in. The inhibitors work against infused factor 8 or factor 9 product. So keeps it keeps the infused factor from working and makes treating a bleed more difficult. So as you, the patient, or you, the parent, are infusing your child or yourself, the factor is being infused and it is supposed to help the body. But what's happening is that we have these little antibodies that are preventing the factor from doing what it needs to do. It's almost as if they're stopping it and saying, no, I don't want you in my body. This occurs because it is something that is foreign to your body also. Patients that have hemophilia A or hemophilia B have a certain percentage of factor in their system, so of factor 8 or factor 9. You have mild, moderate, and severe hemophilia A and B. So those that have severe have less than 1% of factor 8 or factor 9 in their system. So when the factor is infused into your body, it comes into your body and your body is like, oh wow, this is something new. What is this stuff? Not so bad. I'll be okay. It's okay. I'm going to let this one slide. You infuse again and your body says, whoa, this is some more of that new stuff from the other day or from yesterday, but it wasn't so bad. I'm going to let it slide. And so your body may react like that for a couple of times, and then it gets to the point where it's like, you know what? I don't like this stuff. It's been coming in, it's been infused into me a few times now, and I really don't care for this stuff. So I'm going to start rejecting it. So these antibodies start attacking it and prevent it from doing what it's supposed to do. And so this is how you develop an inhibitor. So what are some of the complications of inhibitors? Uncontrolled bleeding, longer recovery time following a bleeding episode, accelerated development of joint disease, and possible hospitalizations for what might be a minor bleed in someone without an inhibitor. So the inhibitors prevent, again, as I mentioned, the factor from doing what it's supposed to do, so it takes longer for the bleeding or the healing of a joint bleed or a muscle bleed to occur. When do inhibitors occur? They always occur. Do they always occur during childhood? Do they usually occur when the very first infusion of factor? Or are you born with it, just like hemophilia? Usually occurs within the first 50 exposure days to factor. And we call, from the time a person starts infusing to the time they're infusing, we call those exposure days. So is it A, B, C, or D? Take a couple of seconds. Let's see what the correct answer is. The correct answer is D. Usually occurs within the first 50 exposure days to factor. And let's see why. So inhibitors usually occur within the first 50 exposure days. However, they can occur after more exposure to clotting factor. One study found 1/4 of patients with more than 150 exposure days developed an inhibitor, and 1/3 had non-severe hemophilia. So many times we think that if someone has severe hemophilia, because they infuse more, they're more likely to develop an inhibitor because the factor is being infused into their system perhaps more often, or at a higher amount when they have a bleed. However, 1/3 of non-severe hemophilia patients also develop an inhibitor. We're going to talk a little bit more about that as the presentation goes on. So who gets an inhibitor? Is it anyone who has mild, moderate, or severe hemophilia and receives an infusion of factor? Only people who are affected with hemophilia A? 40% of people with hemophilia A and 12% of people with hemophilia B? Or all of the above? Does everyone on this list that's listed A, B, C get an inhibitor? Or is it only A, B, or C? Who gets an inhibitor? The correct answer is anyone who has mild, moderate, or severe hemophilia and receives an infusion of factor. So what do we know about who gets an inhibitor? Whether you are mild, moderate, or severe, an inhibitor can occur if you infuse with factor. It's estimated that 20 to 30% of people with severe hemophilia A will develop an inhibitor, and up to 4% of patients with severe hemophilia B. So if you look at my picture that I have here to the side, so among people with severe hemophilia A, about 20 or 30 in 100 will develop an inhibitor. Among people with severe hemophilia B, about 4 in 100 will develop an inhibitor. While it is rare, people with von Willebrand disease type 3 who infuse clotting factor can also develop an inhibitor. And as you may know, many times when an inhibitor develops, it's because of the amount of factor that's being infused or the time that it's being infused. People may be getting a lot of factor at one time for different reasons. They may have a bleed, they may have a procedure, they may have a surgical procedure. Patients with von Willebrand type 3 sometimes bleed the same way as a patient that has severe hemophilia. So those patients tend to infuse more than patients that have, let's say, von Willebrand type 1 or type 2 that may not infuse at all or rarely infuse with factor. So again, it's the exposure to the factor that may cause the inhibitor. Which of the following groups are more likely to develop inhibitors? Those who have another family member who has an inhibitor, people who have certain genetic mutations causing their hemophilia, or Black or Hispanic persons with hemophilia? Or is it letter D, A, B, and C? Or is it E, none of the above? Look over A, B, and C, D, and E real quick, and then I will give you the answer. So the correct answer is letter D, A, B, and C. And let's find out why. So who is at an increased risk to develop an inhibitor? Those with an increased risk of developing an inhibitor include people with severe hemophilia, people who are Black or Hispanic, people who have a family member with an inhibitor, and people with certain genetic mutations of hemophilia. Okay, so that's why the answer was A, B, and C, because it was basically the three of the above answers. People with severe hemophilia sometimes are more prone to getting the inhibitor or developing an inhibitor, as we mentioned. And again, it's because patients that have severe hemophilia do tend to infuse more because they have more bleeding versus patients that have mild or moderate. That's not to say that a patient with mild or moderate hemophilia does not bleed, because we know those patients also, some of them bleed as if they were severe. But patients with severe hemophilia are more at risk. People who are Black or Hispanic, and that is just something that is genetic. We're not quite sure why that happens. And again, as we proceed in this presentation, we'll talk a little bit more about that. And if you have a family member that has an inhibitor, we sometimes say that you are more prone to develop an inhibitor also. And then certain genetic mutations. So, genetic factors. Let's talk a little bit about those. I know sometimes we get into the genetics and we're like, oh, this is a little complicated. But let's see if we can make this just simple, short, and to the point so you get it, so you understand it. So gene mutations. So gene mutations are large genetic deletions. There's large genetic deletions. Inhibitors occur in 88% of patients with multiple domains that are involved. Nonsense mutations are those that a mutation results in a shorter unfinished protein. They may also be called a stop codon. Intron 22, inversion 22, most common mutation in severe hemophilia A, 21% incidence of inhibitor development. So there was a study that was done called My Life, Our Future, and part of that study was doing genetic testing. So patients that had this test done, or family members that had the genetic testing done, when we got back the results, many of those we saw with the inversion 22. So we did see that that was something that was common in patients that had developed an inhibitor also. So this is something that is looked at. Now gene studies, genetics, even when we were in school genetics, I think nursing students that remember their genetics rotation, we're just like, oh my goodness, because it's a lot and it can be a little complicated. But when we look at these, this is what we look at when we look at gene mutations in patients with hemophilia. And again, what we see usually is this inversion 22 or intron 22. Race and ethnicity. Again, as I mentioned, patients that are African American, Hispanics, there we see the development of inhibitor in this ethnicity. And the mechanisms for these differences is unclear. And we're not sure why it is that patients that are African American or Hispanic are more prone to the development of inhibitor. There's still studies that are being done, and we're hoping that we can get some clear answers. But again, with this, everything that's going on with genetics, everything is still being researched, and there's work being done to find out why this is. So here's our little family history tree. And this is where we look to see, you know, you guys have seen this before, the genetics of if there's a father that has hemophilia versus gets together with a woman that is not a carrier, or if mom is a carrier and dad does not have hemophilia, the genetics of what can happen when they have children. And basically, from looking at these, what we see is that if brothers have hemophilia, here, brothers have hemophilia, it doesn't necessarily mean that they will both have an inhibitor. And why that is, we don't know. We do see it, and it is common that if one brother has severe hemophilia or hemophilia with an inhibitor, that the brother may develop an inhibitor also. But we also have some families where there are brothers that one may have an inhibitor and one may not. I remember having a family in our practice that there were 4 boys and 1 girl in the family. All 4 of the boys had inhibitors, and the young lady was a carrier. She did not have an inhibitor. She was just a carrier, their sister. And the 4 boys all had inhibitors. That mom, really, I have to give her credit. I always use her as an example because she had to infuse these kids before they were old enough to infuse themselves, before they left for school. She had to infuse them. She would put them in a line, put them all in a row. She would set everything up and then sit them all down and say, okay, come on, and you, the next, the next, the next. So this is just why I have so much respect for the parents and our patients that have hemophilia, because they really, really are the experts at this. So this mom did this for the 4 brothers. We had another family that had 3 brothers, and the 3 boys also had hemophilia, but only one had an inhibitor. The other 2 did not have inhibitors. And that is great because we don't want anybody to have an inhibitor. But this is just an example to show you how it doesn't necessarily always mean that if one member of the family has an inhibitor, that everyone will have an inhibitor or all the boys will have an inhibitor. Okay, and then there's environmental factors. So the age at versus exposure and the intensity. So it's not predictable. We don't know what will happen. We have children that are born and they may have hemophilia and not need any type of treatment at birth. And many times that depends on the family history versus no family history. If there's a family history of hemophilia, then we know that we need to be cautious. If that mother that's carrying the baby knows that it's a baby boy that she will be having, we know that at birth we're going to hold off on circumcision, that we're going to get a factor activity to see whether the baby has hemophilia or not before we do any circumcision. We also know that there are precautions that need to be taken at the delivery in case this baby does have hemophilia. When there is no family history, then it's more difficult because mother may not have known. We have had some parents, some mothers that were perhaps adopted, so they did not know their family history. They did not know that there was hemophilia in their family. So that may be a little more difficult because if we don't know what the family history is, then if a little boy is born, the parents may decide to go ahead and do that circumcision. And then after the circumcision, that's when we see the bleeding. And once they get all the studies done, if they do their bleeding test and they find out that this little boy has hemophilia, then they start infusing with factor to control the bleeding. So this little boy may be exposed to factor at a couple of days of age versus someone that if we know that there's a family history, we know what precautions to take so that we are aware and know to watch for these, the signs of bleeding at birth. And really, there's no control over when major bleeding episodes can occur. Delay in major surgeries is possible if they're needed, but it's not a reason to withhold treatment. And I want to make that clear. I know that there's patients that may have need some type of a major surgery, and there's no reason to hold a treatment for that. There's lots of treatments now for hemophilia, and hemophilia is just wonderful because there's always something new happening. And with factor treatment, patients can get through major surgeries without having these bleeding episodes that used to occur in the past. So if a major surgery is needed, even though there's going to be exposure and an intense amount of factor that may be used, it's always better to have the surgery, because the possibility, it's much better to have the surgery because we want you to get better, and we can control the bleeding. The bleeding can be controlled with the help of your HTC or hematologist. Individuals who get large amounts of factor in a short period of time. So patients with mild hemophilia having surgery. Sometimes patients that are mild need to have some type of a surgical procedure. And HTCs, hematologists, we come up with a treatment plan for that procedure or that surgery. This may involve perhaps infusing a couple of days, or it may involve infusing a couple of times a week, versus perhaps some mild hemophilia patients who don't infuse, or may infuse on what we call on demand, where they only infuse when they have a bleed. So here they're having surgery and they're going to need to infuse more than they usually do. So this is where we talk about that exposure and intensity again, because their system, their body is not used to having this amount of factor infused into them, and the exposure to the factor is much more than what they're accustomed to. Or perhaps if it's a mild patient with mild hemophilia also, they may not use factor at all. They may use something else for their bleeds, maybe some stimate. But when it comes to having surgery, they may need to have factor to control bleeding that may occur. So this is an example of when large amounts of factor also put a patient at risk for developing an inhibitor. Or an intracranial hemorrhage. Intracranial hemorrhage is something that we as HTC personnel, we worry about, and we try to avoid any type of head injury, because this is this can be very dangerous. But if someone has an intracranial hemorrhage, then yes, they're going to be exposed to more factor than usual, and perhaps an intensity where it's going to be treatment a little more aggressive than when they have, let's say, a joint bleed or a muscle bleed. So these are all examples of when exposure and intensity can cause an inhibitor to occur. And again, if you know anyone, or if you are planning on having a child, it is very important that you let your OB, your obstetrician, know the family history. If you are a carrier, it is important that you let the obstetrician know. If you are the father and you have hemophilia, it is very important that you also let the obstetrician know that you have hemophilia, that there is a history of hemophilia in your family. We did have a family that it was a young man, and he came to clinic and he told me he was going to be a dad, and he was grinning ear to ear. He was just so excited. My question to him was, does your girlfriend know? Yes. Does the OB, the obstetrician, know? Oh, well, I don't know. Did you tell him? Well, I haven't. Did your girlfriend tell them? Well, I'm not sure. Okay, then when you leave the clinic, you will need to contact your girlfriend so that she can contact the obstetrician, or you will need to contact the obstetrician and let them know that there is that you have hemophilia, and that you also have brothers that have hemophilia, that your mother is a carrier. that your grandfather has hemophilia. So this is where the family history is very important. So he did do it. I'm very proud of him, and they had a healthy baby girl. So everything turned out well. But this is just an example of why family history is very important. And that's something that we always spend time with our patients, is family history, especially with our new patients, trying to go back and see how far back this goes. Again, if it's available. Okay, real quick, true or false? The type of factor a person with hemophilia receives will determine whether or not they will develop an inhibitor. True or false? Okay, I'm going to go to the next screen. It can be true and it can be false. This is something that we're still looking into because there's conflicting reports. There's always been, well, not always, but there's a discussion of recombinant versus plasma-derived concentrate with or without von Willebrand factor. So the plasma-derived concentrate with or without von Willebrand factor. So recombinant is the factor product that is made in the lab, and the plasma-derived concentrate comes from actual plasma, from a person, from a live person. So there's always been conflicting reports as to whether it is better to use recombinant or whether it is better to use plasma-derived products. And this is something that I will say more than once during this conversation, that this is why it is important that you discuss all your options with your HTC providers or your hematologist as to what product is best for you or your family member. Okay, so there was a study done, Zip It, and it talked about this plasma versus recombinant. So the results showed a significant increase in inhibitor development in recombinant factor VIII treated patients compared to plasma-derived factor VIII with von Willebrand factor treated patients. 26.8% in the plasma-derived with plasma-derived factor VIII with von Willebrand factor developed an inhibitor versus 44.5% in recombinant factor VIII. So more patients with the recombinant factor VIII developed inhibitors. From this study, MASAC recommended, and it's recommendation 243, in case you want to look these up, because you can. So their recommendation is that individuals with 50 exposure days continue on the same product. So if you start on a product and you have 50 exposure days and things are going well, then just go ahead, stay on the same product. Individuals with between 0 to 50 exposure days, consider remaining on the current recombinant product. So if you're on a recombinant product and you have 0 to 50 exposure days, consider remaining on the current recombinant product. Newly diagnosed individuals and their caregivers should consider the data from the Zip It study and additional available data to make the best decision for the patient. So basically what MASEC is saying is that the patient, the parent of a patient, and the HTC or hematologist need to really discuss what type of product is going to be used and consider their recommendations as to what the product should be and how long they should stay on the product. And if inhibitors develop, then they need to decide whether they're going to stay on the same product or if they're going to use other treatment. And we're going to talk about treatment in a little bit. So testing for inhibitors. How do we test for inhibitors? I have another question for you. Inhibitors are suspected when? A, when there is a change in physical activity. B, when there are no new breakthrough bleeding episodes. C, when bleeding episodes no longer respond to factor infusions. Or D, when a person with hemophilia moves from on-demand treatment to prophylaxis. So what do you think? A, B, C, or D? So inhibitors develop when They're suspected when a bleed does not respond to factor replacement. So the correct answer is C. I'm sorry. The correct answer is C. More factor than normal is given to treat a bleed. You need to treat for a longer period of time, more frequent breakthrough bleeds, and bleeds are unresponsive to factor infusion. So we suspect that there's an inhibitor because we have a treatment plan for you, and you contact your HTC hematologist and you say, I've had this knee bleed for 3 days now and it doesn't seem to be getting better. I'm infusing the way I'm supposed to. I'm doing my RICE, my resting, my icing, compression, my elevation. I'm doing everything that I'm supposed to. I'm giving my factor on time, and yet I'm not getting any better. And perhaps now it's getting worse. I'm having a little bit more pain at this area. So then we start to wonder, and then we start to think a little bit more, and perhaps we're thinking, wow, this is the second time he has this bleed in two weeks. We have another bleed. He had a bleed not too long ago, and they're complaining of a little more bruising. So then we start to think, and we're thinking, okay, we better check this patient for an inhibitor. However, I'm also going to tell you a little secret. Could it have been letter D for those of you that chose letter D? Let's go back to letter D. When a person with hemophilia moves from on-demand treatment to prophylaxis, yes, I could see where people would have picked letter D. And the reason for that is because we talked about on-demand treatment. I mentioned it a little bit in patients with mild hemophilia where perhaps they don't infuse all the time, they don't infuse with that intensity, they don't infuse factor, they may be using something that's not factor, and then all of a sudden we decide or we think that it would be better for them to go on prophylaxis because maybe they're having a little more bleeding or maybe they're bruising a little more. And this could also be a moderate patient because we do have moderate patients that are on demand too. So because of the intensity of the infusions and the exposure to the infusions, we're having them go from just infusing when they need it to perhaps 2 or 3 times a week. Patients that start that type of a protocol, prophylaxis protocol, can also be at risk for developing an inhibitor. So for that reason, it is important to have routine annual screening at your clinic visit. Those that have come in for their yearly comprehensive clinic to their HTC or when they see their hematologist, they should have a inhibitor screening done at least once a year. So how are inhibitors measured? By a blood test, A, by a blood test, B, in a measure called a screening unit, C, by the number of breakthrough bleeds someone has on prophylaxis, D, in a laboratory measure called the Bethesda unit, or E, A-N-E. I'm sorry, A-N-D. So which one do you think it is? Okay, the correct answer is E. It's by a blood test and in a laboratory measured by a unit called a Bethesda unit, by a measure called a Bethesda unit. So inhibitors are measured, as I mentioned, by a blood test. It's called the Bethesda assay, and it's used to detect the presence of an inhibitor. It provides a measure of inhibitor activity level in the blood, a titer. Many times they'll say, we got your inhibitor titer back. And this level is used to determine treatment. If your unit is if your Bethesda is higher than 5 units, you have a high titer inhibitor. If it's less than 5 Bethesda units, you have a low titer inhibitor. And we said A and D because it is a blood test and it is measured in Bethesda units. So why do we test for an inhibitor? We've kind of through the presentation been giving you examples of what can happen with infusion of factor and when patients may develop an inhibitor and what some of the signs are, but why should we test for an inhibitor? Well, most inhibitors develop during childhood, but they can develop at any time because as I mentioned, We may have someone that doesn't infuse regularly, that's on an on-demand treatment, and now we're going to take them to a prophylaxis treatment. You can have an inhibitor and not know it and may not have any symptoms. Treatment will need to be adjusted if an inhibitor is present. It is important to know if there is an inhibitor present prior to surgery or a procedure. The importance of testing. Hemophilia inhibitor research study, the Rheas study. This was another study that was done, and it was done in 17 HTCs. There were 1,163 patients enrolled from 2006 to 2012. 23 new inhibitors were discovered. 61% were not clinically apparent, so patients didn't even have symptoms. 1/3 had non-severe disease, and 1/4 had greater than 150 exposure days. So it's important to know to have the testing done. MASAC's recommendation number 236 from October 6 of 2015 recommends that as a minimum, yearly inhibitor testing should be part of routine standard of care management for all individuals with hemophilia. Testing should be conducted more frequently as clinically indicated. What if I or my child is on imixicimab or Hemlibra? Yes, inhibitor testing can be done while on this medication. Remember, Hemlibra is not factor. The standard Bethesda titer that is routinely done will not work. So your HCP must request that bovine-based chromogenic tests be used. And if you are on ixicimab, this is a send-out test at most facilities. Therefore, it may take longer to receive the results. And make sure they do not do the standard test. So, whereas most inhibitor titers come back maybe in 24 to 48 hours, because it is a send-out test when you're on Hemlibra or imicicimab, then it may take a little bit longer for you to get your results. Okay, so here is my friend Rhea, and she has we have a video here for you to watch on her experience with hemophilia inhibitors.
With severe hemophilia A, and he's had inhibitors since he was about 7 months old. He had to have a port placed at 7 months old, and in the hospital system that we were in, they had not seen a child under 1 year old develop an inhibitor, so they never tested him. They knew he had hemophilia, but they didn't test him for the inhibitor. They put a port in him, and he couldn't stop bleeding. We're dumping factor into that baby. And I literally watched my child turn gray from loss of blood. It's so much better to get tested than to need some type of medical assistance and then find out on the table that there's something that just went completely wrong. So it was scary getting a diagnosis of an inhibitor, but absolutely not knowing it would be a lot worse.
So my friend Rhea, every time I watch that, my heart just breaks. She was very brave for putting this infomercial together for us, and it's very good information, and she is right. It's better to know than to not to know. So that's why it's so important to have this inhibitor testing. These are some quotes from parents, a teen, and an adult. It's important to know, as the adult says, knowing I have an inhibitor means I can prepare for an accident or emergency. The teen, I have an inhibitor and it's hard, it gets in the way of my life sometimes, but at least I know, and that helps me deal. Parents, it was scary getting the diagnosis of inhibitor, but not knowing would be worse. I'm glad I know my son's inhibitor status so we can both be ready in case of an emergency. So it's very important to know if you have an inhibitor. And what happens if you develop an inhibitor? Well, there's many treatment options. You can go with a high dose factor 8 or factor 9 for low titer inhibitors at the time of a bleed. There's bypassing agents, either as treatment for bleeds or for prophylaxis. immune tolerance, high dose factor on a daily or more frequent basis, bispecific antibodies, and new treatments in the pipeline. When it comes to inhibitors, we are left with more questions than answers. Today, inhibitor development is the most significant adverse event that occurs in patients with hemophilia. We don't know definitely what causes inhibitors. We don't know why some, but not all inhibitor patients tolerate, and the quality of life matters. So what can we do? How can you get tested? Some HTCs automatically include inhibitor testing as part of your yearly visit, but it's worth confirming. If they don't offer inhibitor testing, then you can ask for one. So this is very, very important. I hope that all of you take note of this. Make sure that you get at least inhibitor testing yearly. So these are references from our talk today. Please feel free to look through them. If you have any questions on anything with this presentation, please, please, please feel free to email the questions using the Ask a Follow-Up question box for a response. I will respond to them at a later time. And again, a reminder that this presentation will be up on the BDC website at a later time. And again, if you want to rewatch it, and then if there's an option to ask a question, please feel free. I would also like for you to please take a few minutes to fill out the easy session evaluation. Please rate this session. Was it meaningful? Did you learn a new skill? Will you use a new skill? How could this session be improved? And any comments you may have. Your feedback will help us so that we can provide programs for you at the BDC 2021 that will give you information that you need, information that you're looking for, or more information on a subject that is discussed. If you complete this evaluation, you will be entered in a raffle for a $75 gift card, and raffle winners are announced each day. So good luck to all of you, and thank you so much for joining me during this session. And I just wish that I could have seen all of you in person, because that's my favorite part of BDC, is seeing all of you, meeting all of you, and learning from all of you. So please send me your questions if you have them, because I also learn from your experiences, and please let me know what your experiences are. Thank you so much, and enjoy the rest of BDC.